honoring Elohim's mandate. And now for today's message.
Well, hello. Welcome to SHEM Ministries, that is Souls Honoring Elohim's Mandate. And tonight is our SHEM Tonight, that is a Spiritual, Healthy, Enlightening Mandate Ministry. And I am Dr. Anna Shaw Devlin, a family nurse practitioner. And you want me to say it? Do you really? I love what I do. Well, to God be the glory. Another day that the Lord hath made. Let us be exceedingly glad in it. Let us thank Him. Let us rejoice. Because if you're hearing me and seeing me and I'm able to speak to you, we are both still in the land of the living. Those of you who were with us on last night, I mentioned that today was a very special day. Today is my mother's birthday, and I am so blessed beyond measure at my age to still have my mother and my father. And I do not take it for granted. I do not. So today is her birthday, and we are so thankful for her. Also, today is my anniversary on my job. I actually started on my mom's birthday. I would never forget her birthday or my anniversary. And a close friend of mine who was instrumental in me getting this job that I have from home, because 6 years ago it was hard to find a job that was from home in my profession. And today is also her birthday. So the Lord set me up, and I'm just forever thankful and forever grateful. So I ask that you bow your heads with me in a word of prayer. And if you see the topic, the subject for tonight, it is actually a continuation from last week's segment. We talked about the bones. So the topic for tonight is bone density. Anything dense is thick. It is, anyway. So if I say, are you sticks or stones, you'll understand. Bone density. Are you sticks or are you stones? We're talking about osteoporosis, osteopenia, weakness of the bone, and the need and how to diagnose, treat, and maintain our bone density. So to God be the glory. Father God, right now in the precious name of Jesus, we thank you, we praise you, we glorify your name. Lord, I ask that you make the words, this message, clear and very understandable to your people, that they will be able to regurgitate and say to someone else the things that I, Lord, thank you for allowing me to be in a position to teach and educate them. Father, you said in your word that we are destroyed for a lack of knowledge, and in all thy knowledge, make sure we get an understanding. And Father, that is our purpose. That is the premise of this ministry, is spiritually to speak into the lives of your people, healing, educate them on those things that will keep them able to be the vessel that you called them to be, God. Yes, Lord, we thank you, and we speak it into existence because the laborers are few. Few people that are truly willing to get out there in the vineyard and work for the Lord. There's not enough people that are willing to be fishers of men. And if they are willing, are they able So, Father, please bless them in a mighty way. In Jesus' name we pray, amen. Because we're talking about osteoporosis on tonight, and I do need you to know that men are affected as well. More so women, more so small built, European maybe, okay, Asian women, and that's based on the size, and so we talked about that on last week. We got a lot to cover tonight, so I'm not gonna go back and talk about something that we really have addressed in detail. I may mention something, but not like we did on last week. And I do strongly recommend, if you missed last week's segment, that you go back and review and rewind or replay or whatever, okay? But I do want to start out by saying I'm glad you're able to see me tonight, not a picture, okay? But I want to talk about osteoporosis, and I'm going to start out by telling you the definition. And while I'm speaking about the definition, I'm going to put this picture up, okay? All right. So, and this tells you what causes it, but let's tell you exactly what it is. Osteoporosis is a disease that causes our bones to become weak and brittle. So brittle that a fall or even mild stresses such as bending over or coughing can cause a break. Osteoporosis related breaks most commonly occur in 3 places. That is the hip, number 1, the spine, and the wrist. And we talked about that on last week, and I even showed you pictures. I don't think I need to show you pictures anymore, but I will emphasize that osteoporosis is a development through the process of bone remodeling, okay? And when I say bone remodeling, understand that bone has a growth cycle. Just like, we talk about a seed being planted in the ground and it has to, a growth cycle. We talk about, children growing up to be adults and how their body cycles through this changes. There's so many things that God created and gave cycles to, because he knew that living tissue and organs and things needed to be regenerated. They can't live forever. Even your red blood cells have a lifespan. Normally, they live anywhere from 3 to 4 months. And that is how we ended up being able to do a hemoglobin A1C and check and see your status of your diabetes, how well it was controlled. We learned that the glucose molecule piggybacked on top of the red blood cell, and there we go. All right. So everything God created had a cycle, even human life. There's a time to live and there's a time to die. Everything God created. Well, I take that back. We weren't supposed to die, okay? But we know what happened, and we're not going to go back through that. But I believe the Lord knew that man would fall, and that's the reason why, even when he didn't intend for man to die, he still fashioned us where we would live, die, and regenerate in the process. So bone does that as well. So osteoporosis is the loss of bone mass due to an imbalance in the bone remodeling cycle. The lack of bone density causes instability and a greater likelihood of broken bones. Bones undergo change on a daily basis. Really? Yes. Yes, yes, yes. That's why it's very, very important to be active every day. Oh, I ain't doing that today. Get up, walk. weight-bearing exercise that's necessary to keep our bones strong can include and does include walking, the pavement, walking, okay? So don't say, even if you have to walk with a walker or a rollator or a cane, you still are assisting your bones to stay strong. So the existing bone tissue is broken down and replaced by new tissue to provide bone mass. Under normal circumstances, the two distinct processes work together to provide a consistent bone mass. But as a person ages, bone remodeling slows down. But the tearing down of bone tissue continues at the same pace. Oh, so it breaks down at the same pace. It just doesn't make bone as fast as it needs to keep up. Oh, and this imbalance eventually creates a net loss in bone mass. Eventually, it'll get thinner, more brittle. When something is osteoporotic, you can see holes in it. Yes, kind of like a sponge, right? A real sponge that is grown in the sea, right? It has holes in it, okay? So that is what our bone ends up looking like. And this natural occurrence is worsened by not providing basic bone building nutrients like calcium and phosphorus and vitamin D, all the necessary proteins involved. All right, now that I said that was a refresher. I am going to talk and focus on treatment tonight. So we're going to talk about treatment for osteoporosis. That is where we are going to go. And I want to talk about some drugs and things. You can go back and talk about your risk factors, hormone levels. I did tell you that was a risk factor. And with thyroid, and we're going to talk about the parathyroid gland. Tonight, we're going to talk about testosterone in men, estrogen in women, changes to our estrogen, our testosterone, and even the PTH, parathyroid hormone, which stimulates all these other hormones to work appropriately, right, is involved. And the reason I'm taking the time to say that is because treatment can be centered or around those hormone factors, okay? Such as early menopause in women who have had a total hysterectomy. So you lost your ovaries and they prematurely stopped working, not because you went through menopause, but you had a surgical menopause in a sense, all right? Surgically induced menopause. So you lost that estrogen. So of course, even at 30 years old, if you had ovarian cancer, they removed your ovaries, you can end up looking like an old woman by the time you are 50. Yes, because of the loss of estrogen and not being on hormone replacement therapy, which would give you what you lost. However, if you're high risk for breast cancer and things such as that, you can't take those hormones. So it's a never-ending cycle. It is a battle. And after our conversation, you are going to know more. All right? So we talked about the risk factors. You can't change. You can't change your sex, your age, your race. Can't change family history. And you cannot change your body frame size. Now, you can gain weight and put all that extra weight on that little teeny frame of yours. And that in itself is going to cause more problems that we do not want to deal with. So now let's move on. let me say this real quick though before I do move on. Last week I wanted to talk to you about Colles fracture. Remember? And that little piece of paper I lost, I found it. All right, so the Colles fracture. I wanted to specifically say it is a break in the radius, right? You've got your ulna and your radius. Your radius is the size of your wrist, the bigger bone that they use to locate your radial artery when you check your pulse. That's where your radius is. It was named for the surgeon who first described it. So that's how it got the name, right? And it typically, this break is located about an inch. Now, 2.5 centimeters is an inch. And it's an inch below where the bone joins the wrist. So look there at the picture. And the reason why I wanted to go back and show you this particular fracture is because it is very painful. Very painful. So if you fall and you have wrist pain that is very, very painful, that is a pretty much good non-X-ray diagnostic revelation that you probably have a Colles fracture. And the Colles fracture in itself is not easy to acquire unless you have osteoporosis. Okay? That is the reason for the story. That's the reason for it being significant and important for me to go back and tell you this and show this to you. Now, if you were to have this type of injury, please, please, please elevate your wrist above the level of your heart to prevent further swelling. And do not try to straighten your wrist. Why? Well, first of all, didn't I tell you that this radius bone is near your what? Your radial artery. What if you tried to straighten it and it severed and cut your radial artery and you hemorrhage and you bleed to death? And if your arm or hand or wrist is not elevated, you're increasing the amount of bleeding and how fast you bleed out. Ding, 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 ding. That is the importance of going back and telling you this. And probably the reason why the devil tried to, I lost the paper last week. But anyway, it's all said and done. We've done it tonight, okay? Now, we've got it said. Let me pull up some information. I'm not going to go through the bone growth and all of that because I'm going to explain that better to you as we go through medications and talk about them. Now, I am going to bring this up and get rid of that. Wait a minute. Wait a minute. I did it the wrong way. Hold on a second. I got to get rid of that first and go back to me. Then I can pull this up. There we go. All righty. All right. So now, the other thing I want to mention to you, we talked about the bone density scan as far as diagnosing osteoporosis. And I do want to reiterate what the numbers mean. Okay. The lower you are, luckily, that's not good. A negative is not good. All right. So if you get a bone density scan and it gives you this number, right? It is a standardized test. Standard deviation test. Excuse me. not standardized, but yeah, it is standardized. Wherever you go, your bone density score should be the same. So wherever you had one done in Europe or you had one in France, and then you come to the United States, the results should be the same. So the lower you go, the worse, in a sense, your osteo. So -1 to -4. So if they say you're -3, -4, not good. Okay. And whether or not you qualify for certain treatments based on insurance, medications, this, that, and the other, they have to factor in certain things. You can't just, because the medications to treat osteoporosis are not cheap. I'm just going to tell you. They're not cheap. And you, just like we pay for convenience, you're going to pay for convenience. You get an IV infusion once a year, guess what? It ain't going to be cheap. You get an IV infusion every 6 months, it's not going to be cheap. But if you take the pill every day, that's probably about the cheapest way to go, all right? But there's certain things that you have to do when you take the pill. And a lot of people don't want to do all of that. And so, it is what it is. But the bone density scan, like I said, normal is anywhere from -1 to a +1. Okay? All right, so there we go. And high normal is +1 to +4. So the more plus you are, and I ain't talking about plus size, okay? The more plus you are, the better. All right. Now, we also talked about prevention was diet and exercise. I've already reiterated that. Now, treatment, medications. All right. So, unfortunately, the only herbal whatever that you could take to treat osteoporosis is prevention with your diet, calcium in your diet. Eat adequately. Those are the things that and your diet and exercise are the only preventions for you. Getting your vitamin D, right? So calcium cannot be absorbed in your body without vitamin D. Just know that, okay? Your bones cannot get strong except there's calcium and phosphorus. Calcium and phosphorus marry. Now, when I say they will never divorce, there is no such thing. Calcium and phosphorus together will bond and make your bones strong. The only issue would be is if you lose calcium, and we're going to talk about that when we talk about medications, and we're going to talk about our parathyroid hormone again. So you don't want low calcium. You want to be able to absorb it. So your calcium, your vitamin D, and your phosphorus are a must. And so the bones, the equipment would be the calcium, phosphorus, and the vitamin D to allow your bones to be strong, but keeping them strong. You got your hormones and you need your weight bearing exercises, okay? So that this remodeling, you don't lose more than you're gaining. All right, there we go. We got it. All right, so medications. I already told you about, and that's, as a matter of fact, that's called a T-score. T-scores that you get with bone density. And low, which would be like osteopenic, would be -2.5 to -1. So -1, -2.5, okay? And then your -2.5, -4, all right? I found that on my little paper. All right, there we go. So, sticks and stones. Do you have sticks or do you have stones? You got to have a bone density scan to know. Oh, to confirm. I take that back. You can have an x-ray. And the x-ray, especially when you have a break and they do the x-ray, most of the time the radiologist will say decreased bone mineralization. The radiologist cannot tell you the degree of decreased bone mineralization, whether or not you're osteopenic or osteoporotic, but they can say looking at this x-ray, there's decreased bone mineralization. It's up to you to follow up, as they said, and get a bone density scan. I don't care how old you are. If you have an x-ray that says decreased bone mineralization, and I said it, and I want you to remember it, because if your doctor doesn't know your history, I need a light to come on in your head. The doctor didn't know you had an x-ray because you forgot to tell them that you had an x-ray that said decreased bone mineralization, because you're not the right age yet to have an increased risk for osteoporosis. This is where our lack of knowledge and depending totally on a doctor hurts us. You have to have knowledge yourself to put the pieces of the puzzle together. They only have 15 minutes, okay? All right. And once you have a fracture, especially a long bone fracture, hip, the mortality rate is significantly higher. What's mortality? Death. Okay? All right, there we go. So, please remember some of the things I say. All right. So, let's now talk about the bisphosphonates. And guess what? I got it written there for you. Bisphosphonates. Bi means two. Phos means phosphonate, phosphorus, two, something to deal with, maybe a phosphorus. Yes, you got it. And where's my paper where I had it really spelled out for you about the phosphorus? I got 4 pieces of paper and I forgot to number them. But these are, anyway, don't worry about the pharmacokinetics. Anyway, how about I just read what I wrote on this paper? I typed the paper myself. Let me just read it. It's my stuff. There it is, phosphonate groups. Okay, and that's the reason why they're called bisphosphonates. But bisphosphonates, no, up to 5 years is recommended that you take a bisphosphonate when you have osteopenia or osteoporosis. 5 years, up to 5 years. It depends on what your doctor's recommendation. And guess what is going to guide how long you stay on the bisphosphonate? You got to go back and get the bone density scan done to see if there's improvement. But the cheapest is up to 5 years orally. Take the pill, but you got to take the pill every day. Or getting intravenous infusions for 3 years. Okay, have you had your 3 years of the IV yet? Guess what? You got to go back and keep going. But these are the first line therapy for osteoporosis. I didn't say preventing with calcium and phosphorus and vitamin D. I said once you have a diagnosis, this is first line treatment. Well, what is a bisphosphonate? All right, look up here. I even took the time and put some examples of bisphosphonates up there for you. I didn't put the generic names, but I put the trade name. Fosamax. See? Fosamax. The other name for that is alendronate. And I'm going to give you a little secret, little whatever. Anything that ends with a ronate, R-O-N-A-T-E, R-O, ronate, on the ending of it, it's a bisphosphonate. Okay? It's going to build your bones. So when you make a decision not to take something, Don't stop the Ronate unless you know for a fact that your bones are strong, or unless you have overwhelming side effects. Now, one thing that people have to do after they take Fosamax that a lot of people have a hard time doing, and they end up having GI side effects, right? Is they don't, or they forget that you gotta sit up. You have to sit up, or if a person is unable to sit up. But if you're gonna take Fosamax, you have to sit up for at least 30 minutes after taking, okay? Or you'll get the GI side effects. And I'm gonna pull it up to see if it even, yep, here we go. It even tells you in the literature. Give with water 30 minutes before your first food. So on an empty stomach, yes. Before your first food, drink, or medication. And you must avoid lying down for 30 minutes. If you are vitamin D deficient, calcium deficient, or low calcium vitamin D, it's strongly recommended that you take calcium and vitamin D supplementation. Okay? If you are not able to adequately get enough in your diet. And guess what? The only way to know is to get your blood checked. The proof is in the pudding. All right? So I guess in all of what I'm saying, please, prevention. Prevention is the way to go. And reassess the need for treatment in 3 to 5 years. All right. So depending on what you are doing or taking or whatever, the medication that you're taking, that will let you know how often you need to get a repeat bone density scan. But for the most part, it's 3 to 5 years, because you got to understand how long it takes for the bone itself to be remodeled. All right. And side effect wise, I am going to, because I didn't write all the side effects down, but I do know that GI is one. People who have kidney disease, where your creatinine clearance is less than 35, is a contraindication. You cannot take this medication. Okay? So when you are stage 3 kidney disease, and that is usually the marker where you have to start making sure your clearance is a certain amount. People who have an esophageal stricture, remember what I said about not being able to lay down, this, that, and the other? If you have a narrowing in your esophagus, because there are people who end up having to get their esophagus stretched. But if you have a history of esophageal stricture, it may not be wise without knowing that you are treated, okay, appropriately. But I'm not going to go through all the side effects and contraindications. Well, no, the contraindications. But side effects include abdominal pain, acid reflux, acid regurgitation, nausea, dyspepsia, which is the burping all the time, constipation, diarrhea, musculoskeletal pain, pain in your muscles, gas, flatulence, and photosensitivity, which is you're sensitive to the light. Now, if you got history of migraines, your photosensitivity more than likely is associated with migraines. But these are some of the side effects that I do want you to know about. Now, as far as the dental, the osteonecrosis, so the bone necrosis, Anything that's necrosed is something that is broken down. So the bone in the jaw is broken down. That is a serious reaction, but it can happen. And like I told you on last week, that is the reason why your doctor will ask you if you take a bisphosphonate, okay? And I told you on last week how that was the reason why they will ask you for your medication list. All right, now, other bisphosphonates are Actonel, Boniva, Zometa, Iridia, Norixia, okay? And I've got those listed there for you. Those are the main ones. So if you see any of those up there, you know that you take a bisphosphonate, all right? And let me keep on explaining a little bit more about them. Remember what I told you, tonight is going to be teaching and education about the medications that are used to treat osteoporosis, because I want you to understand certain things. All right. Bisphosphonates are a class of drugs. It's a class of drugs that prevent the loss of bone density. So if you have osteopenia and you do not want to develop osteoporosis, that would be the time that I can start taking a bisphosphonate if necessary. Your doctor will help you decide, but at least have an idea what's available, okay? So, and it has to be benefit versus risk. Remember what we said. Potential contraindications and side effects. And they are the most commonly prescribed drugs used to treat osteoporosis. They are called bisphosphonates because they have two phosphate groups. They are covalently linked to carbon. Determine both the name and the function of the drugs. Carbon? Uh-oh. We're going to get there. So, sometimes you will hear them called diphosphonates. But it's the same thing. Bi and di. Evidence shows that they reduce the risk of a fracture in postmenopausal women with osteoporosis. Now, I know someone who recently had a fall and had a quote unquote possible fracture to their wrist. Guess what? I need them. This is a spiritual, healthy, enlightening mandate ministry. I'm speaking to them, but I'm also speaking to you too. That person, when they fell, if they had not already received treatment for their osteoporosis, guess what could have happened? The fracture that they encountered could have been a whole lot worse. They could have had a Colles fracture. And so what I'm trying to say to you is this: be wise, be smart. If God has put wisdom and knowledge and understanding in your path, and you do not take heed to the information, and then something happens. So am I trying to tell you that you can avoid the severity of something? Yes, I am telling you that, okay? What was the purpose of taking the COVID-19 vaccine? It did not say that you would not get COVID-19, but it said it would decrease the likelihood that if you did get it, you wouldn't die. Okay. All right. The most popular ones are the alendronate, which is the Fosamax, and the other is risedronate. Risedronate, which is Actonel. So the two that I have listed up there, these are the most common that are prescribed, Fosamax and Actonel. And what in the world? The computer changed my Actonel, Actonel, to Antonella? What in the world? But that's a computer for you. And I didn't catch it, so I do apologize. All right, so those are the most common that are prescribed. But if these are ineffective, so you've taken them for 2-3 years and you had a repeat bone density scan and they weren't effective, or if the person develops a digestive tract problem that I mentioned, intravenous, we all know what intravenous is, right? That's IV. Pamidronate may be used. What is pamidronate? That is the one that I have up there called Aredia. Aredia. That is IV, and that may be what's next recommended for you. All right? And we can spend forever on that, but let's keep going because I want to talk to you about a little bit more about some other medications that are used. All right. Let's now talk about the pharmacokinetics. Now, what's the pharmacokinetics? That is the way the medication is broken down, metabolized in your body. These are some things that you need to know. Of the bisphosphonates that are reabsorbed, the ones that you take by mouth, from the oral preparation or the one that is infused for IV drugs, about 50% of it is excreted unchanged by the kidney. So, that's the reason why they have to know my kidney function before they can give me the medication. And periodically, especially if you're teeter-tatter on the edge, they're going to stay up with your kidney function before they continue to give it to you. They have no choice. Okay? And even if you don't have kidney disease, how about you can get dehydrated and decrease your renal function and your creatinine clearance and how well you excrete drugs. That's the reason why sometimes we don't act right. Think, something wrong. They ain't acting right. They seeing things. They're hallucinating. They talking all whatever. They can't remember nothing. They whatever. Could it be because medication is building up in your bloodstream and you're not getting rid of it out your kidneys because the medication is primarily excreted in the kidneys and you're dehydrated because you haven't been eating or drinking, or because of the fact that you've had nausea, vomiting, and diarrhea and you're not able to keep anything down? That happens too, and that's acute renal insufficiency or acute kidney injury. Okay? Got it? Okay. All right. So much is involved. We need people to stop trying to diagnose and treat themselves without contacting someone. And I'm going to say this. I know I'm getting off on a little tangent. I do not know an insurance company. Insurance companies want to save money by keeping you out of the hospital. And I do not know an insurance company that has not put in place the nurse line. Call a nurse and ask. Yes, and they also have the pharmacist that you can ask. You can even call your pharmacy and ask. Guess what? Every time you get a new medication, they're required to print out literature and give it to you. And guess what else they're required to do? consult with you. You see that window that says consultation? Because it doesn't make sense if you don't know what you're taking and why you're taking it and side effects and what you need to monitor, right? And then you end up in the hospital. The insurance company has to pay. Then the insurance company in turn jacks up your costs or your copay for your medicines. It is a never-ending cycle. It's a battle. You scratch my back, I scratch your back. The drug companies start charging more to make more of the medication that you need to take because you didn't know how to take it. And the insurance company said, we're going to charge you more because you jacked up our or decreased our revenue, right, by being in the hospital all the time. It is what it is. My mama told me that her mama told her that there won't nothing free in this world. And guess what? That was the truth. So, understand that out of the 50% that is excreted from the kidney, the remainder has a very high affinity for bone tissue. Oh, so when something has a high affinity for something, that means it's going to attach itself. Oh, yeah. So the other 50% is rapidly absorbed onto the surface of the bone. That's how that bisphosphonate works. Once the bisphosphonates are in the bone, they have a very long elimination half-life that can exceed 10 years. Are you for real? Yes. So my goal in taking this bisphosphonate when I'm osteopenic, so that I don't become osteoporotic, and then I take it appropriately, and I stay well hydrated, right? Take it like I'm supposed to, I got a 50% chance of getting 50% of that medication in my bones. And when it gets in my bones, it's got a 10-year half-life. What's a half-life? That means that the medication itself is going to do what it's supposed to do and not decrease by 50% until 10 years. Whoa. Oh, that's good to know. That's good to know. All right. So, remember what I said about bone tissue undergoing constant remodeling and is kept in balance. I told you this word, that the Lord was good when he decided to make everything equal. It's called homeostasis. How is bone homeostatic? On last week, I told you that there was something called osteoblast and osteoclast. So the osteoblasts create bone. So BB, blast bone, make bone. The osteoblast makes bone. The osteoblast makes bone. But the osteoclast destroys the bone. Carry it away. Class, carry it away. B bone, osteoblast makes bone, osteoclast destroys the bone and carries the dead bone tissue away. Okay? So the bisphosphonate inhibits the digestion of bone by encouraging the osteoclast to undergo what is called apoptosis or cell death, slowing down bone loss. So, oh my gosh, really? So the osteoblast makes the bone. I told you that bone has a life cycle. So at the point where the osteoclast says, you know what, it's time for you to go. You done spent enough time and it's time to go. So as you age and you don't produce as much, you don't have as much osteoblastic activity, but you still lose bone at the same rate, the osteoclast, this bisphosphonate says, stop right in your tracks, right? It's like the policeman with the, well, that's not a good analogy. I was going to say the policeman saying, halt, don't move. But that's not, we don't want to joke about that, okay? But the bisphosphonate says, stop right where you are. I am going to stop you from destroying this bone and causing death of the bone. And it slows it down. Didn't say it would stop it, but it slows it down to the point where, can we create homeostasis where you still make as much bone as you're losing? Can we slow down that aging process by taking the bisphosphonate? Yep, you got it. Okay? The bisphosphonates, when they are attached to the bone tissue, they are also released by osteoclasts. Okay? Just understand that. Once I get on board, I'm going to hold on and I am not going to let go. All right. And actually, the way it explains it here, it says bisphosphonate molecules then attach to and enter the osteoclast. See, I forgot about that. It gets into the osteoclast where they disrupt the intracellular enzymatic function. Now, enzymes are anything that kind of eats away and breaks something down, right? So the bisphosphonate gets inside the molecule itself, disrupts it in the cell, intracellular, needed for bone reabsorption, so it doesn't get reabsorbed into the body. All right, so I think we did pretty good on explaining that, because that is something that you really, really, really need to understand. I can tell you all day about preventing osteoporosis, but like I told you, there's certain things, risk factors that you can't change. So at any given time, any of us may be privy to finding out that we're a little osteopenic or whatever. And remember what I said, it runs in families too. So if the humpback thing, you see men with the humpback too, right? And I didn't even talk about other bone diseases. I just talked about osteoporosis. But there are some, remember we talked about people who have to take steroids, right? Increase your risk for bone demineralization and things. The adrenal gland. That was last week's lecture. All right, Anna, stop it. Go back and listen to last week's lecture, because I'm not going to go back there. We're going to move forward because we're almost done. Now, the next drug that is on there, do I have it on there? Prolia, I wanted to talk about. Did I not put Prolia on there? I thought I did. I am so sorry. Denosumab. And that, I thought I did. All right. Well, I am so sorry. Please forgive me. But denosumab, Denosumab. But it's called Prolia. And you've probably heard about Prolia. Prolia, because a lot of people who can't take the alendronate, right, the oral Fosamax and they end up taking Prolia. Now, these are injections that you can get every 6 months to improve your bone density more quickly than a bisphosphonate. Oh, so you're telling me that the bisphosphonates that I have to take every day, if you're unable to take them every day, and you're osteoporotic, and your vision is poor, you're unsteady gait, you don't walk well, you're really at high risk for a fracture. We ain't got time to be waiting no 3 years for no bisphosphonate to do what it needs to do. You're in a situation right now that you need intervention. You need intervention right now. So you can get these injections every 6 months and they work faster. I need you to know what's available. That is the reason why I said we were going to spend a whole part 2 talking about drugs, because honestly, knowing and how to identify and not understanding the treatment, right? That's not going to do you any good if you don't understand how important it is to take the medication and how and understand and know what's available to you. Okay? So, you can improve your bone density more quickly with Prolia. Although bone density improvements fade within months after you stop the medication, unless you have taken bisphosphonates. That is the reason why when you finish your treatment, they many times will keep you on a bisphosphonate. Okay? All right. And that is a discussion you and your doc should have. All right? Because it just depends on you. It depends on your, remember, the T-score, on your bone density scan. It depends. It's a lot of stuff involved. Now, I do want to talk to you about parathyroid hormone analog therapy. What in the world is that? Let me just say PTH, parathyroid hormone. Okay? PTH. Parathyroid hormone analog therapy is a synthetic form of parathyroid hormone that we make naturally in our body. The Lord thought of everything. He thought of everything. He thought of everything. If you don't believe me, I'm just telling you. He thought of everything. All right? And it can be used to treat osteoporosis. And there is a synthetic form. It's recombinant PTH that is used in postmenopausal women at risk for fracture. These are other options. And it can be used for up to 2 years. Guess what? It dramatically improves bone density and reduces your risk of fractures. But there's always everything that was created, that God gave man wisdom and knowledge how to create. They all have side effects. And that is what I need you to always remember. Do not take something and not think about or understand that everything has side effects. You have to weigh out the benefit versus the risk. For example, you get married, right? Your wife gets on your nerves. Your husband gets on your nerves. You have to weigh it out. Is there more good than bad? Is there more positive than the negative? Is there more benefit than you feel me? There's everything in life. Everything. You buy a fancy car. Can you make the payments? Can you afford to get the car serviced? Can you afford to put gas in it? The risk versus the benefit. The benefit of driving that fancy car and the risk of repossession because you couldn't afford to make the payments. Just saying. Okay? It's life. So, but this parathyroid synthetic hormone significantly improves bone density and reduces fractures, and I'm getting to tell you why. But also, let me throw this out there too, but it requires subsequent bisphosphonate use to maintain the benefit. So it's kind of like I need something and I need it in a hurry. It's kind of like you pay extra money to have overnight shipping because you need that tomorrow. You can't wait a whole week for UPS ground, 5 to 7 days. You need it tomorrow. So you pay the extra money, you get it right away. Okay? But if it's something that you need routinely, you still got to pay shipping to keep it coming to your home or wherever, your business. So it does require subsequent bisphosphonate use to maintain the benefit of it. So the thing I want you to remember about PTH is that the parathyroid hormone, which is in our pituitary gland, that the Lord in his infinite wisdom made when he made man. And he did it how fast? But the PTH regulates the distribution of calcium and phosphorus or phosphate in your body. Phosphorus that you eat in your food turns to phosphate, just in case you didn't know. Phosphorus, phosphate. But the parathyroid hormone regulates it, the distribution of it, okay? Distribute things evenly. That homeostasis I mentioned, okay. So the synthetic form works by increasing bone calcium levels, improving your bone formation. Increased parathyroid levels in the body, right? So you're taking this synthetic, you're increasing your parathyroid hormone. It increases the calcium level in the blood by transferring calcium from the bones into the blood. So you got to be careful. You're not just going to get no PTH analog unless you really, really, really need it. Understand that. So don't walk up in there saying, I want that PTH analog. No, it don't work that way. It also increases the absorption of calcium by the intestines and your kidneys, your renal tubules in the kidney. The calcium levels in the blood decrease with a decreased PTH level. Now this is getting a little technical, and I'm going to abandon trying to teach you about PTH. When the level is high, this drops. The main thing, the reason for me bringing it up is because I want you to know that certain medications such as that are going to cause you to have too much calcium or too little calcium, okay? What's the significance of that? Some people develop bone, extra bone that causes pain, problems, that can cause growths, that puts pressure on nerves, that can possibly contribute to cancer. Woo! Yes. Got it? So don't be taking somebody else's medication either. Okay. Now, so this PTH analog would be given periodically. You don't get it no every week, no whatever. Periodic administration of a recombinant PTH stimulates bone formation in both men and women. The examples of this medication, oh shoot, I did not put them up there. Uh-oh. Now, these medications don't have ronate on the end because those are just bisphosphonates. But There's one called abaloparatide. So guess what's so funny about that? Parathyroid and paratide. Paratide, parathyroid. Para. So there's one called abaloparatide, and the other is teriparatide. And I apologize for not having their generic name. Well, you know, wait, I take that back. There ain't no trade name for these. These are what they are. Each one has its own mechanism of action, but the end results are the same. So depending on which one you would get, depends on you, your kidney function, your calcium levels, okay? Because people can have high calcium levels and it'll be a trigger for cancer, like I said. All right? And as a matter of fact, whenever I look at labs on a person, I hate to say it, but one of the first things I think about is cancer. The second thing I think about is looking at their med list to see, are they taking calcium and vitamin D and they're, so if it's medication induced. But the first thing I always, for some reason, that comes to my mind is a person has a calcium level of 11 and 12, I think cancer. Okay? All right. Because if cancer were to metastasize to the bone, and there are some cancers who go to the bone first, or by the time it gets to the bone, you got stage 4, and it is in your bone now. That's why they check for lytic lesions when they look at an x-ray. The radiologist will. I'm just giving you just a little extra info, okay? And they look at that stuff. Dad, you mean to tell me I went to get a chest x-ray because I kept coughing and they did the x-ray and come to find out, then they made me do a CT scan and blah, blah, blah. Next thing I know, I got a diagnosis of metastatic bone cancer. Woo! But it metastasized to the bone, but the origin may have come from somewhere else, like your intestines. Okay? Little extra. Side effects. Remember, side effects of taking some of these medications can cause elevated calcium levels. That's the reason why I said you got to look at the med list. Now, there's a new kid on the block, and I know I'm a little over, and I do apologize, but there's 2 things left for me to talk about, and it ain't gonna take me long, and you will be okay, because you can stop and come back later if necessary, okay? There is something that you can take once a year, and I did not look at the cost. I should have done some research, but it's called Evenity. 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 And it is romosozumab. Romosozumab. Remember what I told you about Prolia? It is a Sumab as well. One of those, it's denosumab, is Prolia. This Evenity is romosozumab. Okay? All right. But it's once a year treatment. It is a sclerostin binding analog. Don't even try it. Just know that it exists. It's called Evenity. And after you get this, you take a year of alendronate. Remember what I said? The ronate, it's a bisphosphonate. And they reduce fracture risk more than 2 years, reduces your fracture risk. More than taking 2 years of alendronate therapy alone. So You mean to tell me I can get this once a year treatment of Evenity, and that's like taking 2 years of a bisphosphonate? What? It's worth it if the benefit outweighs the risk. Okay? Keep that in mind. Now, I want to tell you about this controversial treatment, which is kind of, I ain't gonna say it's controversial, but the way I am, what do I always say? Kill 2 birds with 1 stone. Okay? So, the risk of you having high cholesterol and increased risk of heart disease and all of that increases with hypertension. It increases with diabetes. It increases with cigarette smoking. It increases with so many things. Family history, this, that, and the other. Okay? Anyone that's diabetic and you're over the age of 45, blah, 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 right? The recommendations for a statin. Well, guess what? Oh, statins. Those are cholesterol-lowering medications like pravastatin, atorvastatin, Lipitor, and Pravachol. Those medicines, okay? Don't act like you don't know what I'm talking about. All right. But statins are a class of drugs that inhibit a HMG CoA reductase pathway. What in the world is that? Don't worry about it. Just hear what's coming out of my mouth next. Unlike bisphosphonates, statins do not bind to bone surfaces with high affinity. And they're not specific for bone. Nevertheless, there have been studies that have reported that people who were taking statins had a decreased rate of fracture, an indicator of osteoporosis, and or an increased bone mineral density in statin users. What? So the people who were taking a statin, they had increased bone density and had a decreased rate of fracture, because when you have more dense bone, you do have a decreased rate of fracture. Okay? But we don't know why yet. Hasn't been figured out yet. But guess what? Wait and see. So the overall efficacy of statins in the treatment of osteoporosis remains controversial. However, if you can kill 2 birds with 1 stone, you taking a statin because you high risk, blah, 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 tell the Lord thank you. Tell him thank you in advance. All right? I am Dr. Anna Shaw Devlin. I thank you so much for listening to me tonight as we did our part 2 on bone density. Are you sticks or stones? And if you are a stick, you can fix it. God bless you. All right. Until we see you again, we should probably more than likely see you on Sunday. All right. God bless you. Mwah. All right. Take care. And I do pray that you have a restful night's sleep.
Thank you for watching